Good morning, all. I thank the organizers for giving me this wonderful opportunity, and also I would like to thank my students and colleagues who made this all happen. Changing trend in trochanteric fracture fixation. For the past 50 years, the prevailing concepts in trochanteric fracture fixations are the anatomical reduction does not matter, it always collapses to stability. The principle of DHS. As it collapses to stability, the shortening and varus are acceptable. Following surgery, the union without implant failure is more important than stable anatomic reduction. Unfortunately, these concepts of 50 years are proven to be wrong. The pitfalls in trochanteric fracture fixations are lateral displacement, lateral migration, implant cutout, pain, and shortening. Most of us would have come across such cases. To prevent such complications and the need for the resurgeries lead to the emergence of newer concepts like fracture reduction, new implant design component fixation with or without augmentation, augmentation of bone implant interface. We have included this in our study. Let me first start with the implant design. Nowadays, the choice of implant is based on the stability of the fracture. So, it is of paramount importance to decide whether the fracture is stable or unstable, for which X-ray alone is not sufficient. Most cases appear stable in an X-ray are actually found to be unstable in CT. So, need to this newer 3D CT classification or a fragment based classification. This this is three fragment in which the part of the greater trochanter appears to be a separate, and four fragment in which also the part of the lesser trochanter is also separate, and five fragment in which there appears to be a breach in the lateral cortex. So, we follow this 3D CT classification to decide whether the fracture is stable or unstable, ultimately which helps in decision making of an implant choice, and also whether the augmentation which is necessary or not. Once the choice of implant is made, coming on to the next important point is this fracture reduction. Previously, much importance was not given to this fracture reduction. Why this fracture reduction is more important is we have come across cases like this in which the fixation, though it appears to be stable with the newer implant designs, with less accurate reduction ultimately lead to failures. In order to avoid such failures, the most important step in fixation would be reduction, that is anteromedial positive cortical reduction, called as Chang's criteria. This Chang's criteria has three types. One is positive reduction, nothing but the proximal part appears to be protruded in AP and lateral view with respect to the distal fragment. Otherwise, it is also called as valgus reduction. If the proximal fragment is in line with the distal fragment in AP and lateral view, and it is called neutral reduction, otherwise an anatomical reduction. If the same proximal fragment appears to be receded when compared to the distal fragment, it is called negative reduction or a varus reduction. The most important point which he emphasizes positive reduction, that is the proximal part has to be protruded with respect to the distal part. So, once we have emphasized this Chang's criteria, moving on to surgical steps. This 55 years old female with history of trauma has presented to our OPD. Initial X-rays appears to be stable. 3D CT, it is unstable and TFN is planned. The initial assessment of the fracture in AP and lateral view under the CM shows negative reduction. So it is so obvious that this fragment appears to be receded when compared to the distal fragment. So we have the first step is to convert this negative reduction into a positive reduction, which is being done with a long artery forceps through a separate percutaneous technique. Once this becomes positive reduction, we fix this provisionally with a K-wire. The point which I want to emphasize on passing a K-wire is never defer this step, as it can lead to loss of reduction. One. Second thing is that this wire has to be passed in the anterior half of the lateral cortex so that it is not a hindrance for the further procedure or the insertion of the nail. Following provisional fixation, the next most important point which we emphasize is the entry point. The entry point should be just medial to the tip of the trochanter in true AP view. So I emphasize this word true AP view, that is that in order to obtain or to identify whether this is a true AP view, you have to internally rotate the hip so that the smooth curvature of this trochanter is visible. And likewise, the entry point in the lateral view is almost at the line joining the neck of the femur, center of the neck of the femur with the shaft in true lateral view. So remember, this true lateral view is not the 90-degree lateral view which we normally think of. What we have to do is you have to rotate the C-arm to the level that this, up to this level, that this neck appears to be in line with the shaft. It usually falls between 75 to 85 degrees. Otherwise, we are trying to avoid the anteversion. Following the entry point, reaming, coming to reaming, we have to ream this in parallel to medial and anterior cortex in both an AP and lateral view. After introducing the nail, the guide wire for the distal screw locking bolt should be passed as much as close to the calcaire just to improve the purchase of the screw. This is the final position of the nail. This is an immediate post-operative X-ray showing positive reduction with a stable fixation. Indication for augmentation. This is case 1. This 57 years old male with a history of trauma. X-ray shows stable pattern. 3D CT taken. There it appears to be 3 fragment as per 3D CT classification, and we could all see a banana fragment which is present over here. This banana fragment is nothing but it is the displaced part of posterior trochanter. It is a displaced and separated part of posterior trochanter is called as banana fragment. If this fragment is left alone, what happens is this fragment migrates medially, ultimately leading to a functional disability. So, such cases we augment with SS wire in a cerclage pattern. So, this is the percutaneous method of applying the SS wire. Final nail position. This is the postoperative X-ray where the reduction is positive and the fixation appears to be stable. Coming to the case 2, this 52 years old male, history of trauma. Initial X-ray itself is unstable, 3D CT taken, and in 3D CT it is a 5 fragment as per 3D CT classification, because there the lateral wall comminution is so obvious. It's a known fact that whenever there is a lateral wall comminution, there won't be a hold for the locking bolt if it is been applied through this, for which we augment such cases with trochanteric support plate and this trochanteric support plate prevents the migration of the screw and it helps and aids in reduction. This is the post-operative X-ray. The reduction appears to be positive and fixation is stable. With this, the carry home message is 3D CT classification is mandatory to identify the unstable fractures accurately. So, always take a 3D CT classification, whatever it is. Second is anteromedial positive reduction, Chang's criteria. This one single step can prevent failure of reduction and also the failure of implant. So, the second most important message is anteromedial positive cortical reduction. And the third is augmentation done appropriately avoids failure. Thanks for patient listening. Thank you all.